Well, hello, everybody. Good afternoon. My name is Garrett Schmidt, and I am the CEO and managing editor for VBC Exhibit Hall. And I'd like to welcome you to today's live webinar hosted by Roji Health Intelligence. And today's session is part one of a two-part series called Best Value-Based Care Strategies for a Cost-Focused Future. And today's session is titled Part One, Strategically Manage Your VBC Payment Models. We've got a lot of information to cover today, so I will rush through my little intro here and turn it over as soon as possible. But I think you're really going to enjoy the presentation. There's a lot of good stuff, and we're going to be sharing a link afterwards to the recording as well as to the slides so that you'll have those to review. And I'm sure you'll want to again because it's going to be a lot that we're going over. And that way you can also share that with colleagues and friends. And also, we are going to have a time for some Q&A towards the end. So if you have a question for either of our speakers, go ahead and drop that in to there's a place for questions on your module there as an attendee. And so we're going to get to as many as we can. If we don't get to yours for some reason or are unable to, we run out of time or whatever, don't worry. Someone will reach out via email to make sure that we get that question answered for you. So without further ado, I wanted to briefly introduce our speakers today. We have with us Ms. Terry Hush. She's the CEO and co-founder of Roji Health, and also Dave Halpert, and he is the client chief of team. So welcome, Terry and Dave.
Thank you, Garrett.
Thank you, Garrett. Thank you, Garrett. I'm excited to be here on this topic today. And everybody's been talking a lot about costs. So we have a ton of stuff to present today. And I'm going to let Dave introduce himself. And then I will do the strategic parts of the setup and then the final piece. And Dave will be talking about some of the payment models.
Hi, everybody. My name is Dave Halpert. As Garrett said, I'm the chief of the client team at Roji. And as Terry said, I will be talking about a couple of the primary care-based payment models, some specialty models, and then go into a little bit on Medicare Advantage.
Okay. So here's where we are right now. Things are just kind of tumbling down around us, and we have a healthcare landscape that is changing because of a lot of cost focus and kind of taking down the pillars that we were used to. And what I'd like to know before we get really going into the content is kind of a pulse of who's listening today or who's watching us. And that is, does value-based care create the opportunity to rebuild a better healthcare system? And A, in these pretty swimming fish in the sea, yes, we're all in, or B, no, we don't think that's going to happen because there aren't going to be enough resources. So Garrett, will you run the poll?
I will run it. And so you will see this pop up on your screen here. And this is anonymous, by the way. So this is just kind of more for fun, and we'll show the results here. But again, the question is, does VBC create the opportunity to rebuild a better healthcare system? Yes, we're all in, or no, not enough resources. So we've still got results coming in here. So we'll give it another 10 seconds or so, and then we will
I'm
close it
excited
down.
to see the results on this one.
Yeah, I'm seeing them coming in. I'm getting a little bit of a preview here. So
How are you? I hope everybody is responding on this one. It's really important.
yeah, very important. And again, this is anonymous. This is just for fun, and we'll show the results. And so yes, we're all in, or no, not enough resources. Okay, I'm going to go ahead and shut it down in about 5 seconds. 4, 3, 2, and 1. All right, is it what you thought? Yes, we are all in at 77%. And then
Wow.
no, not enough resources at 23%.
Wow. Oh, I love talking to optimists. So that is really great to know. And I'm glad we did that poll because it gives me a really good flavor for the conversation and maybe some of the questions you'll have too.
There is hope yet.
There is hope yet. even though we have a lot of pelicans fighting over a single little fish, and we know that we're going to be losing resources out of the system, the things on the table right now, everybody I think is aware, research grants, revenues coming from actual reimbursement formulas, kind of the underpinning of Medicare and Medicaid reimbursement, support for medical education, payments for uncompensated care, big question about what will happen to the Medicare or Medicaid program. So all of that is the backdrop for what we'll be seeing. And although all of these are really specifically aimed at hospitals and hospital systems as well as eligibility, we also know that these are going to be affecting the entire system of healthcare. On the provider side, we'll see changes in hospital staff. It will affect the 51% or 50 more percent per the latest numbers on employed physicians. We'll see changes in residencies and residency slots. So that will affect the supply of physicians going into the system. Specialty physician research will be affected. The support staff of providers, clinics, FQHCs have been targeted by some of the most recent cuts. And then it will affect both the rural and the urban environments in healthcare. So big change in the provider side of the system. It will also obviously affect our patients, access to primary and specialty care, wait times, treatments, clinical trial availability. The cost share of care will probably go up for patients, vaccine availability, especially under some of the new directives for research, and then routine and preventive care. Will people even be able to access that kind of care? There are questions about Medicare Advantage and will it be the future of Medicare? So I think we need to understand the government perspective on this, and having sat in government shoes for a number of years, I understand the kind of attraction that comes with fixing costs and fixing them through a capitated payment structure. Well, all you have to do is tinker with that every year and not deal with all of the claims and the structure that involves paying or providing access to healthcare. It's kind of a fiduciary responsibility as opposed to a responsibility for access to care for patients. It's popular with beneficiaries. That's kind of the, depending on how you're looking at Medicare Advantage, it's a reason why government can say, well, it's very popular with beneficiaries. They like this program, so we should like this program. Of course, it privatizes the problems of Medicare, and it looks like smaller government. The real question from our perspective is, can value-based care save enough? So here we have essentially Joan of Arc running through the crowd with her great sword. All of these cuts that I've just referenced, they're one-time cuts. They won't fix it because one-time cuts just lowers the base. You still have the escalating costs of healthcare to deal with. The only reductions that can make sense and we can achieve through value-based care is through addressing the total cost of care or total per capita cost, depending on how you're, dividing that same concept among people. And to generate that kind of reduction, you need to improve patients at the highest risk. What we see, however, has not been a great track record, even though we see really good escalating costs of ACO savings. When you look at those savings as a part of total traditional Medicare spending, just in 2023, we see a tiny sliver, almost insignificant, as part of the total spending picture. So the imperative we have to look at, if we are really going to change and make value-based care the incentive or the program to change costs, is a significant win. We have to slay the dragon. We can't just kind of tinker around at the edges anymore, or value-based care will end up not being the tool that gets adopted by Congress and by those who are in the system, because it won't matter. We need to recognize, though, that value-based care requires resources, and here are some of those. I will address them further as part of strategies later, but data, analytics, technology, improvement programs, patient tie-ins, interventions, communities, those are all part of a value-based care universe of tools that we need to make sure that we have in place in order to do anything with it. And now I'll turn it over to Dave to talk about some of the specifics of the payment models.
Thanks, Terry. Yes, I'm going to start with the primary care models because they are the ones that are intended for the broadest impact rather than a targeted focus. So let's dive in. The first one, obviously, is shared savings ACOs. This is by far the largest of the primary care models, 476 ACOs. It's built on fee-for-service. There are about 29% of ACOs have zero downside risk, but the rest have some downside risk, depending on the level of the track that you are on, whether you are on the basic track or enhanced track. There is a cap on downside risk between 8 and 15%, but of course, those are substantial numbers if you are in that range. As we saw from Terry's earlier slide, and we can move ahead one here, we've got a pretty steady stream of savings. It started slow, and then there was exponential growth. And as Medicare has put forth in some of its documentation, experience has been the greatest predictor of how much an ACO will save. The longer that people have stayed in the program, the better they do. And that is where the selection bias comes in, is that if you are not doing well, you figure maybe it's better to try your hand at MIPS rather than remaining in an ACO if it's just not financially feasible for your organization. And that is what happened with some where one-time fixes could not produce continued shared savings. It's very easy to get that low-hanging fruit, but that is a rabbit that can be pulled out of the hat just once. The next one I'll cover is ACO Reach. We remember ACO Reach as realizing equity, access, and community health. Now all of those references have been stricken from the website of ACO Reach, and it now mirrors a lot of the same language that was in its earlier iteration, the global and direct contracting models. They are capitated. They are capitation-based rather than fee-for-service based, and you can take two options. There's either a primary care only option or a total cost of care option. And it scores total cost in addition to claims-based outcome measures like readmission. It is a voluntary model, so again, we're going to see some of that selection bias. It's intended to increase ACO development in rural and underserved areas. The original pool is shrinking, no new applicants until the model concludes, assuming that they go on. Now let's look at the results. There we go. People are doing well. About 70 or about 3/4 of the ACO Reach participants have achieved savings, and that is 2.6% net savings to CMS when compared to the benchmark, of course. Similar to ACOs, the people with the higher rate of risk that they have selected are the ones that are doing better. Again, that's your selection bias for you. If you think that you are going to make your targets, you're going to go for that higher level of risk. You're going to put in a little extra skin in the game because you know that that is going to come back to you in the form of shared savings. Gross savings increased per beneficiary per month, again, almost 3/4 compared to 2022 levels. CMS attributes, again, the improved performance here related to experience, and then the actual improvement of performance of the applicants.
So if I understand this right, Dave, we've got about 130-ish ACO reach, and we've got 476 ACOs, but the ACO reaches have been generating a larger share of savings than the shared savings ACOs. Is that
Yes,
right?
yes, that's correct. That's correct. Although it is tempered by the fact that some of them have dropped. The numbers are, there was that initial pool, and so we do have some that are dropping.
So it's worth considering that this might continue or blend with the ACO model even.
I think that's a very fair estimate.
Yeah, me too.
The next one on the docket is ACO PC Flex. Again, voluntary and low revenue ACOs only. So the difference here is that it is built on that fee for service structure rather than a capitated structure. There are prospective payments and advanced shared savings in order to sort of prospectively fund primary care. Like ACO Reach, there was an equity strategy that was highlighted on the site that included rural health clinics and FQHCs. Again, that has been stricken from the website. Interestingly enough, the applicant pool for this one is heavily comprised of ACO enablers. And so the big question here with regards to ACO PC Flex is, will the government continue to fund upfront, or will they continue to provide upfront investment? Because one of the recent developments is that a non-ACO version of this, called Making Care Primary, was originally supposed to be a 10-year model with a lot of the same components, wherein there was an upfront provision for primary care services and a shared savings aspect. Like I said, it was supposed to go for 10 years. A directive was issued earlier that CMS intends to shut that program down after just 2 years at the end of this year. So that is the question for ACO PC Flex is, will it continue as well, or will it go the way of Making Care Primary?
It's kind of an interesting question because this is composed of the ACOs that were in the regular shared savings program, right? And just
Yes.
so it's a target group. And to the extent that it moves that group who may have been risk averse for low revenue physician led groups into a prospective payment program, maybe that's the big thing that it serves in this that might make it continue.
Yeah,
Big question.
indeed. So with all of these primary care models, there are similarities and differences. Essentially, the biggest similarities are there is an attempt to correct for under-resourced care, and that means providing additional finances. There is going to be some financial risk, though, and there is an arc towards capitated payments. There are some differences. Some of them have a different focus on population. Obviously, some of them are based on a fee-for-service chassis, while others are built on capitation. Some have a larger breadth than others, and some of them may include Medicaid in addition to Medicare. So now we'll go into the specialty models here. I do like this. It illustrates the big difference in the specialty models is that you are departing from the main road and looking for a specific outcome to improve upon.
Good graphic for that.
Yes. It also reminds me that there are some places other than here where you can actually move quickly on a highway. Not something we're seeing much here in Chicago. Anyway, the first one, I digress, is BPCI Advanced, the bundled And so we're trying to move responsibility here from patients to the bundled payment for care improvement participants. And what we're wanting to see is successful recovery, particularly as measured by reduced readmissions and complications, the things that are going to have the highest cost associated with them. And that's what you see in the quality measures, is the looking at total cost of care plus some quality measures within the episode. Now, the catch for people who are participating in BPCI Advanced is that the total cost of care includes all costs within the episode window, including things that may or may not be within your control at all. So it is quite a challenge to manage that if you are the participant who is just performing the surgery. Another challenge within this program is that they do not look at one procedure on its own. It is bundled payments for bundles of different services. And so that loses clinical integrity. It's very hard to determine where something is going wrong or where something is going right when it is lumped in with something else. So if you were looking at, let's say, an orthopedic where you're looking at all lower extremity joint replacements, there's a lot that gets bundled in there that is hard to find. It is hard to sift and find the gold that exists there when there is so much that has been put in the same pot.
Yes, and in cardiac, the same. You see different approaches
Mm-hmm.
to different problems, even um, all part of the same bundle. So, to the extent that there's cost variation between those procedures as well, it can really mess up the line on average cost.
And different providers have, or excuse me, different practices have different specialties as well.
Right.
So you have your let's say your hip people and your knee people, or you've got your cabbage people versus your vascular people, and it becomes a challenge. All right, let's look at the results though for BPCI. Selection bias. I hope everybody's picking up a theme here. There is improvement, but in a voluntary model, there is going to be selection bias. And so, uh, again, the theme of voluntary models leading to selection bias. It started off not so great. It started off losing money, but then a bunch of participants dropped. And the ones that remain, the amount that they saved wound up eclipsing the amount that was initially lost. So there actually is a case to be made for the program's continuation. Uh, but again, voluntary model, will that be the case if it becomes mandatory in some areas?
And it kind of overlaps with some of the other models too, doesn't it?
Yes, it does. There are other models as well, and so sometimes patients will be, depending on how CMS performs the attribution on each model, whether or not that patient is attributed as a BIPSI patient versus, let's say, an ACO patient or a Kidney Care Choices patient. It is all done after the fact through that analysis of administrative claims and program rules.
Right.
The enhancing oncology model is the next one. This was the outgrowth of the oncology care model. And the goal here, similar to BIPSI, is to improve coordination and decrease the patient's burden for trying to coordinate their own care while they are undergoing chemotherapy. Again, reducing total cost of care is the financial goal. Reduce the total cost of care that is associated with chemotherapy. And because it is a total cost of care model, Medicare does pay specific attention to people who have specific additional comorbidities because those need to be managed. In addition to the chemotherapy, the problems associated with those do not go away just because the patient is going through chemotherapy. And so to ignore them is done at the patient's peril. The financial structure is based on a 6-month episode of chemotherapy. And there are performance-based payments or recoupments, PBPs and PBRs, based on whether or not um, the, um, the the practice comes in underneath the target price established by CMS. There are two commercial payers, speaking of payers, that are associated with the enhancing oncology model as well, and that's something that we may see more frequently in models going forward.
Sorry, I didn't mean to flip that slide. Um, One of the things that I think is really interesting about this, and we're very familiar because we have a platform that serves this model, and it is really hard for this kind of basket of 6 month episodes of patients, which can include patients who are just entering chemo, or patients who are leaving chemo, or patients who are the entire 6 month period is in there. So it is a time segment that doesn't really allow for inspection of the total cost of care during that. So we've had to build a lot longer episode based on an entire chemo episode to enable the groups to be able to look at that and see where the costs are really different.
Yeah, the that 6 month period, obviously CMS needs to have a finite start and end for each performance period to score, but it is definitely an artificial one, and it does make it challenging for participants to understand where, again, things are going right or wrong.
Right. So you can affect the total cost of care by looking at the total episode, and then it will ultimately affect the 6 month episode by bringing down
Exactly.
those costs. That's
Exactly.
so it's kind of the way the analytics and the actual provider responsibility goes has to be to address that total cost with, but still have an effect on a 6 month treatment span
Yep, absolutely.
bucket. I would say it's not even a 6 month treatment span. It's a 6 month bucket, just like the BPCI.
Hmm. Yep. And speaking of procedural-based episodes, the other one that I wanted to cover here is the team model, transforming episode accountability model. Again, we've got some of the same procedures that are in BIPSI, also some of the same procedures that are in those MIPS cost measures. You can see here how CMS is trying to dovetail certain quality programs together so that there is consistent measurement. There are several different types of procedures that are a part of the team model right now, but the purpose is all the same. We're trying to avoid emergency department utilization and inpatient visits, looking for faster recoveries, transition back to primary care, and creating equitable outcomes. The big difference here between team and BIPSI is that for certain geographic areas, the team model is mandatory. So maybe we'll get some answers to our previous questions on what will be the fate of BIPSI and will it evolve eventually into an accountability or a team model that is mandatory. There are three risk tracks. One of them, the first one is zero downside risk um, for a year. For safety net hospitals, it can go up to 3 years. Track two is the lower levels of risk, even lower for some rural hospitals. And then track three is the highest level of risk. It's a much more condensed time frame than ACOs.
Of course, that's current. All of that could change as
Yes, indeed. Yes, indeed. We will have to see whether or not there is that lead up period because
tolerance, yeah,
yes.
tolerance level.
Well, what we saw the first time was the what happened with the shared savings model, where there was a real push on how long somebody was allowed to stay in
Mhm.
without risk.
Right.
Um, Again, the pillars of specialty payment models are very similar, capping the total cost of care, and then change the way that incentives are paid, trying to avoid rewarding volume and looking more at efficiency, keeping people out of the emergency department, out of the inpatient side for complications and readmissions. And they are tending to look at the highest cost and highest volume clinical areas, something where there is going to be a noticeable and measurable effect. Each specialty model has benefits for both specialists and for healthcare networks. For specialists, you've got your predictable revenues, and you can market, if you perform well, you're able to market that with real hard numbers to patients. You're also able to market it to health plans. Healthcare networks and ACOs have the ability to reduce some of that variation as they refer outwards and also get a better handle on where they should be referring patients for specific procedures. It helps them to develop a more narrow network. And again, the ACO can use that to negotiate with other health plans besides Medicare. Now, that assumes that you have a platform built so that you can look at that clinical episode and identify variation and cost drivers, as opposed to just looking at the feedback that CMS gives you and taking a shot at changing without really knowing the effect of your intervention and whether the changes are associated with that intervention or just chance and circumstance. There also needs to be transparent data for collaboration as well. So your how-to guide, invest in infrastructure. Those things do not happen on their own. Having that episode view, that's something that is likely going to need to come from elsewhere. Looking at enhanced data collection and identifying disparities. So even though there are the equity and social determinants of health are coming off of a lot of the website, it's still well documented, the relationship between social determinants of health and outcomes, so that is something that you are going to need to be aware of. Looking at all patient quality reporting and cost and utilization measurement, so that eventually you are able to align your quality strategy with multiple payers. That way it's more efficient. You're not trying to perform X for payer 1 and Y for payer 2 and Z for payer 3. You need a nice cohesive quality strategy, a single superior standard of care. So the last thing I'll cover here is Medicare and Medicare Advantage. I'll spare you all of the details in this chart, reading them aloud, and just give you the basic summary that is Medicare is like a PPO, and generally Medicare Advantage is an HMO. So you have to look at how whether or not you think you would like to have greater access and potentially pay more out of pocket, or to have a narrower set of clinicians that you can see that along with prior authorizations, but have less of a potential pull on your wallet. As we can see here, people have spoken, and many of them are going for the Medicare Advantage route. You can see that on the left side, the hard numbers, we're seeing greater Medicare Advantage enrollment, but also on the right side, it is as a proportion of the Medicare eligible population, you're seeing that increase as well. So it's not just a question of the volume going up because more people are becoming eligible for Medicare. It is actually within the Medicare program as well. We're seeing a lot more. Now, the elephant in the room here is that Medicare Advantage pays much higher than traditional Medicare, but that money benefits the plans and does not go directly to the patients. It's because we're looking at capitation here. It's a fixed per patient cost or first per patient payment, regardless of the services delivered. And so, like other programs, there is a financial incentive to restrict care. It's been an argument with many of the programs where you're looking at trying to save money. The difference here between Medicare Advantage and some of those other programs is that the Medicare Advantage program has commercial payers involvement, shareholders, stockholders, and Medicare does not, and therefore it is less concerned about some of that compared to some of the publicly traded companies. Um, there is an impact on patient care, an undeniable impact on patient care. In 2023, there were 3.2 million prior authorization denials, meaning that the patient was not able to uh, access specialty care. The denials that were appealed were mostly successful, almost more than 80% actually. And so the net result for those is just simply that care was delayed, um, and that there was some impact on the provider side. I'll talk about that in a minute. But limited networks also restrict patient care, especially for complex patients. The American Society of Clinical Oncology did a study that patients with very complex cancer and did not have access to like a high volume academic medical center, the post-surgery mortality rate was higher. And so that's something to consider as well. And that's what we're seeing, where some of the patients who have started on Medicare Advantage when they were relatively healthy, suddenly when they are not as healthy anymore, they run into issues. There's also an impact on providers. Those prior authorizations and denials can choke revenue streams. And some providers have actually opted out altogether. It's not a large chunk in general, although there is definitely some specialties where that is more represented, particularly on the mental and behavioral health side. Um, the original Medicare payments, traditional Medicare, we know that those are not keeping up with inflation. And then when you look at the other side, the MA side, we see higher reimbursements, but they're offset by those delays and denials. And so there was a study recently, or a survey recently, that 61% of health systems that were surveyed have either stopped accepting Medicare Advantage altogether, or are looking at stopping something within the next year.
All right, we're hearing this a lot. I've gotten a lot of feedback about groups exiting the program.
The federal government certainly has benefits to gain from Medicare Advantage. Fixed costs per person, it's very easy to manage. It fits into the privatization strategy that we are seeing from this administration. Also, it will decrease federal staffing needs because, again, privatization. We've all seen the slashes to the employment at in the federal government. It also gets the government out of the business of claims adjudication and the insurance business altogether, things that they would be happy to privatize.
Okay, and so now we'd like to spend a couple of minutes talking about how to construct your strategy in light of these payment models. And the choices look somewhat similar. On the primary side, you basically have different ACO options or Medicare Advantage plans. I put a question mark besides Reach and PC Flex because we don't know whether they will continue to exist as separate private programs or whether some of the features of these will be folded into, let's say, another track in the ACO model towards risk, giving ACOs time to get into a population-based payment. On the specialty side, I think the question is, does BPCI Advance stay, or does it morph into something that is either like the oncology model, which is a treatment kind of program, or TEAM, which is a procedural program? And then, of course, MA plans can deal with some of the negotiations with specialists on specialty models too. The overall message, not all models will survive here. I think that the complexity of having a lot of different programs with the Innovation Center, it's always been a target in some, in the conservatives in Congress, and I suspect that we will see a shrinking of those models even further, as we've already seen some terminate in the last couple of months. So we have a most models voted most likely to survive and regenerate or morph into different models. First of all, the shared savings, because it's a proven model, it is generating savings. It will likely morph into having payment features of ACO reach in the future, or which will take both the primary care flex model and the ACO reach model and incorporate it into the general ACO. So you can have a number of different options, but at least it was standardized some of the other components of that program. Medicare Advantage, I think that will obviously survive. There's a strong interest in that from the administration. And all they need to do is really adjust some of the issues regarding denials at this point. The enhancing oncology care model is a really interesting specialty condition episodic model treatment program. It could be applied to chronic disease, the kind of segment in here, it could be applied to any kind of medical specialty as well. So like heart failure, for example. I think this is a model that has some real legs in the future because it does have risk. It is focused on both quality and cost, and it provides a strong incentive to the groups. And we're seeing this from our own clients who are in this model to really care and focus in on the things that are driving their costs. It's been a super experience to examine that. And then, of course, the team procedural episodic payment, I think that is likely to survive and expand. Right now, it's in 5 different regional areas. It could easily expand beyond that and become the prototype for paying surgeons. So the overall, as a summary, the probable future is that ACOs will continue, but that risk will be required or will start to dominate the market, that there will be a global or population-based payment, either with PCPs or on the total cost of care. If ACO reach saves money, the component of that will survive. It doesn't mean that ACO reach as a separate model will survive. Specialists, we see mandatory episodic payments being the future here, especially for the high volume procedures like TEAM. Medicare Advantage growth, we're already seeing projections on that growth in the future, and I think we're likely to see that continue. And that payment models themselves will not all be voluntary. There may be those who are put in payment models depending on costs. So what do you need to think about as far as building a cost-focused future and strategic plan? Well, first of all, don't waste your time on models that are not going to survive. So I would, even if they were open, I would look at the opportunities that present themselves for these episodic specialty models and for ACOs, if you can accept that risk is going to be a part of that. You need to accept that risk is going to be a part of any ACO. It will probably also be a part of MA as that goes forward. So I don't think there's really any escaping the fact that there's going to be a reduction in fee for service as a percentage of overall reimbursement. And that's not all negative. Some of that is going to be positive because it will provide a predictive revenue stream for you, but it also takes some of the pressure off creating volume as your primary motivator through reimbursement. Focus on your core strengths, primary or specialty or both, and then of course organize the tools, and that's what we'll talk about here. So what you need to make value-based payments effective at cost control, first of all, aligning your incentives to cost control, and that gets at this issue of, am I pushing volume through my reimbursement? Is that how I'm rewarding my providers? or am I pushing better care and cheaper in the end while maintaining quality? Aggregate your sources of data. That means EHR, your cost data, and your claims data. Those three things are essential. You cannot build an episode of care without being able to get incoming claims data, because if that patient is seeing other providers outside your view, you won't know it. And so it needs to feed both primary and specialty care models, and that view has to be 100%. That's what curating your data and analytics mean. You need chronic disease episodes of care, and you need episodic episodes of care that are procedural and treatment areas. Both of those will give you a great idea of your patients who are falling into higher risk categories in chronic disease, anticipating the utilization that comes out of that, and being able to address it through interventions before it actually happens. That is what building a pipeline of improvements and interventions for patients is about. Understanding your risk from the data, acting on that risk when you see the potential for things to go amok, and then sharing that data with providers so you can involve them in the solutions and interventions and improvement programs. Let's talk a little bit about pivoting. A lot of organizations are trying to address pivoting right now for value-based care reasons. Aligning your value-based care, patient-centric approaches with clinical teams led by physicians is a proven strategy for actually improving burnout rates, improving the physician's capacity to actually manage care, and then dividing up the responsibilities that are not top of license to other clinicians and paraprofessionals to do that. So responding to patient expressed needs is another area where we don't really address the convenience and price transparency requests that patients have made for a long time. That needs to be an imperative as part of your value-based care strategy, or you will continue to see patients shopping around for different systems and different providers, and that's not what you need for value-based care. You need loyalty and collaboration with that patient. Building the support for physicians to provide patient information and management programs to help them make better decisions about their lifestyles and changing the trajectory of their outcomes is a key element of your value-based care. And so physicians need to understand what they can do and not have to do everything in terms of communicating all of the information to patients. It can be handled and offloaded from physicians. But sharing the data with physicians, particularly cost data, with most providers not sharing that data now, is an essential strategy to involve them in value-based care. You cannot collaborate with a group of physicians based on lack of data. They have to trust that the data you are using to evaluate their costs is vetted through their own view of that data. What do you need to ask of payers? So at least 45% to 65% of your business is private health plans. And for a long time, payers have refused to provide digitally patient-identified claims data, demanding use of portals, canned reports, giving, agnostic aggregate data. All of those are not enough for you to be able to manage costs, and they don't help you build the episodes that you need to be able to actually look patient by patient and examine the variation in costs. You need that data. You can get it. I got it as an employer. I was able to negotiate claims data with every single payer that I had under contract. It can be done, but you need to have it a condition of your willingness to enter into ACO type or specialty agreements with those payers. The ability to choose and collaborate and negotiate payment rates with specialists under global payments is going to come up, and you will need to be able to ask that ability of payers to do that. I think it will happen under the CMS programs so that ACOs will be able to negotiate or collaborate with specialists under global payment programs and do like they were able to do in an old IPA, is negotiate those global payments. Consistency of quality and cost measures across payers. It's so burdensome to be able or to have to meet all the individual criteria in different payer reimbursement formulas, and it ought to be a demand in your contract negotiations. So these are all contract negotiations. How do I set my negotiation strategy with payers? If I was a clinically integrated organization, this would be my list. The reality is that revenues will shift from fee for service over time. Right now, it's kind of a poison mushroom. You've got incentives in there. It's 92% of all payments to healthcare providers right now, but it's shriveling. And you will end up going into the other camp with population-based payments. You will have to decide which of your products, which of your payers give you the trust and the ability to control costs that you need in order to go into that population-based payments, and you need to articulate those in that process. But these things will shift whether you're ready for it or not. So create your own tools to be able to get to that place where you will have to shift your payments to population based. Don't lose your head. This is wrapping up right here. Don't lose your head. You have to anticipate the future, use data driven strategies to achieve success by identifying your high risk patients with data. And that means total episodes of care data, collaborate with specialists, involve your clinicians in performance improvement strategies. We are way past the time where you can have like one or two initiatives on performance improvement a year and then demonstrate that as some providers do under the MIPS program. We are talking about wholesale improvement over all your high cost areas and a grand strategy to really bring the cost down to survive in the market we are entering now. And negotiate with payers based on your ability to control the costs. And now we are open for questions. We don't have much time though, I think. Garrett.
That's right. We do have some audience questions, and obviously there's a lot of material here to cover. And you're right, we also don't have a whole lot of time. So we'll get to a couple here, and then we will move forward. All right. But if you have a question, go ahead and drop it in now. If we don't get to yours, don't worry. Someone will reach out via email.
Yeah, we'll
So
answer them by email.
for sure. So first question here is, given that physicians are already in short supply, how do you expect them to react to cuts? Will they leave Medicare?
Well, I'll answer that one. We have not seen them leave Medicare in the past. And I think that um, I don't think that we will see a huge flux of that in the future. But they will, I think there will be a give and take for a very short period of time on the global payments that will allow them to get used to the idea of what needs to happen, and they'll stay in.
Great. Next question here is, ACOs have resisted risk for a long time. What makes you think that they won't just leave the program when population-based payments take hold?
Because no matter what program they're in, there will be risk. I don't think that we're looking at just the Medicare program as a risk-based program. We're looking at the whole market moving towards risk. Because as Medicare drops its funding, either through the reimbursement formulas or bad debt or residency, all of that lower cost is shifted onto the private health plans, and they're going to be in the same boat. We've seen it before. We know there's a cost shift from Medicare and Medicaid to private plans, and they will do exactly what Medicare has done. They have done it for years, for decades. So there
And
is
also,
no
what's
escape
yeah,
from it.
yeah, and what's the alternative to suddenly disengage with all of the practices in the ACO and have everybody do MIPS on their own? That's the reason that a lot of them have kept going or have joined ACOs in the first place.
Mhm.
Yeah.
Plus, you've got a huge private equity market now that is built up around value-based care, and they do start to have the tools to be able to manage this risk. They've certainly geared up and amassed the data to be able to do some of that. They haven't had all of it, and I think they haven't had what they need to from the private plans. But that will that will stabilize some of the providers who are in there too. I think the biggest issues are going to be the large academically based and large system providers who are who are not equipped to move into risk quickly. They will have to get on board, and it's been kind of a resistant. Some have been working hard on data, and some have moved forward, and others have not. And so, some those who have not will need to get up to speed.
All right. Well, unfortunately, we are out of time. We do have some other questions that came through, but again, if you asked yours, don't worry, someone will reach out to make sure we get your question answered. But wanted to thank you again, Terry. Thank you, Dave, for a fantastic presentation. Obviously, there's a lot here. We're going to be sending out a link to the recording, and that way you can review it and get the slides and whatnot. But as we close out, wanted to encourage you all to head over to vbcexhibithall.com and check out the Roji Health Intelligence virtual exhibit booth. And Terry, if I could have you go to that next slide. There is a picture of it there. And this is where you can really learn more about Roji and what there it is, what they're doing in the space, and really drill down on them and kind of see what they're up to. And if you would like to, of course, reach out to them, there's ways to do that through there. Also, you can view some of their other webinars. They've done a lot of, probably more than anyone else, of webinars. We have done so many with Roji, and they have so much great material. So all of that is archived there at the library at VBC Exhibit Hall. And then finally, if you'd like to reach out directly to the Roji team, to Terry, to Dave, to Leonard, they will point you in the right direction and help you out. And of course, you can also reach out to me. I'm happy to facilitate an introduction if that's easier. But thank you all so much for joining us today. There is going to be a part two. And I am actually going to, kind of on the fly, go ahead and put a link in the chat. And sorry, I didn't do this earlier, to register for part two. But we will be actually sending out in the email that we send out, we will include a link to where you can register. But let me go ahead and drop a link here in the, let's see, in the chat. And that way, if you would like to, as we're closing out here, you can go ahead and click on that. But thank you all again so much for spending the rest of your day. And again, we'll leave this up here for just a minute while we're closing out. So if you would like to click on the link. But thank you all so much for joining us. Bye-bye.